Hello, good evening at 7:01 p.m. This is the virtual event for prostate cancer awareness in the era of COVID-19 pandemic. We've got a beautiful list of local expert panelists. We've got, this has been organized by the North Shore NAACP branch in partnership with AdMeTech Foundation. And we've got Dr. Faye Stern, founder and president of that foundation here. Thank you, Dr. Stern, for partnering with us. I think that AdMeTech does fantastic work around advocacy and awareness. They have a wonderful program. Please check out their Facebook page. It's AdMeTech and then Manogram Project, if I pronounced that correctly. They do amazing awareness campaign work to improve our community's health. So please support them. We have a beautiful timeline. I also want to recognize Senator Creighton this evening that's in attendance, and Senator Joan Lovely that is in attendance. We did get a late positive RSVP from Senator Tarr, who might be coming in either through the Facebook door or Zoom, but thank you for making time for that, senators. We do have, what I'll do is I'll go ahead and just launch into introducing Senators Creighton and Senator Lovely, really as champions of the prostate cancer educational program for high-risk men with the priority focus on African American and Hispanic individuals. They've both done a lot of work in that space. Really, I don't have any more in the way of an opening statement, so I'll go ahead and just pass it over to Senator Lovely to please say a few words.
Thank you, Natalie, and good evening, everyone. It's a pleasure to be with all of you tonight, and I'm so pleased that we were able to convene this conversation virtually. I want to thank the North Shore NAACP and AdMeTech for this invitation to offer some brief remarks. I've had the pleasure of working with AdMeTech and Dr. Stern over the last several years. Dr. Stern is an incredibly powerful advocate for AdMeTech and the work that they do to ensure our communities of color are getting the screening they need to diagnose and treat prostate cancer. Racial inequities in our health system, unfortunately, are not new. They have been prevalent for many years in prostate cancer, in maternal health, and in overall indicators of health. The COVID-19 pandemic has thrown these inequities into the spotlight, and it has exacerbated them substantially. We are all aware that communities of color have suffered disproportionately at the hands of COVID-19. Black Massachusetts residents had COVID at nearly double the rate of white residents. For Hispanic and Latinx residents, the rate was more than 3 times higher. These numbers are truly staggering. But for those who have been following racial inequities in our healthcare system, it likely has not come as a surprise. As we move into our new normal, the life with COVID, it's imperative that we take a hard look at how we got here and how we can move forward toward a more equitable healthcare system. I know this conversation is a step in that direction. I am grateful to both the North Shore NAACP and AdMeTech for their hard work and dedication to eliminating racial inequities in health, especially for men of color in prostate cancer. So thank you for the opportunity to join you this evening, and I'm honored to be here with my colleague from Lynn, Senator Creighton. Thank you so much.
Thank you, Senator Lovely. Thank you. And welcome Senator Creighton, who also has been very, very supportive of the work that AdMeTech has been involved in.
Thank you, President Bowers and Dr. Stern, and to Senator Lovely, who's been a champion for this for so long. It's great to serve with her on so many issues, but in particular when it comes to health issues and health disparities. To be on this panel is very humbling for me, and I will be brief because all the real experts here we want to hear from. But thank you for all that you do for my community and for the Commonwealth in general and keeping us healthy. I would like to recognize AdMeTech's work on awareness, education, research on prostate cancer. As an aide for Senator McGee, I think is when I first met Dr. Stern, and she was educating me then, probably a decade ago, and then as a state rep, and now as a state senator. So some would say I'm a slow learner, but she's been very persistent, and I know that's how she approaches advocacy across the spectrum. I'm also very excited about the development of the North Shore NAACP. Look forward to working with you not only on this, but also advancing racial equity across the North Shore, both related to public health and more broad issues. And events like this are critical for having conversations with public health experts that are here, with information grounded in science and data, which is all too often lacking in our public discourse these days. So this event is so crucial and so important. And I think the timing couldn't be more appropriate. Just earlier today, the state announced that all Massachusetts residents 18 and older are eligible to receive a booster shot. So we're hoping folks get out there and do that. Obviously, between the summer and now, we've seen a big uptick in COVID cases, and we should get the booster shot with the same sense of urgency as we did for the original vaccine. So I encourage everyone to sign up as soon as possible. I think it's the most important thing we can do right now for those that are already vaccinated. As everyone here knows, we've seen great disparities in vaccination rates. And this is also a great opportunity for us to discuss that, to make sure that we're signing up for boosters and for children to beginning to get vaccinated as well. AdMeTech's long brought attention to this, as I mentioned before. Prostate cancer affects 1 in 7 men, and with even higher rates in men of color. Black men have a 60% higher rate of occurrence and are 2.5 times more likely to die from prostate cancer. The earlier we get screened for prostate cancer, the better we are to receive high quality care. I'm proud to represent the city of Lynn, which I should have said from the outset, which is obviously a very diverse community. And I think getting information out there like this panel is tonight is crucial for my constituents, but also for folks across the North Shore and the Commonwealth. So again, I thank you. It's an honor to be here, and I look forward to hearing from the real experts shortly. Thank you.
Thank you, Senator Creighton. Now, I'd like to introduce Dr. Philip Rice. He is the chairman of emergency medicine at the Mass General Brigham Salem Hospital. And he is going to talk about the current status of the COVID-19 pandemic in adults in the North Shore and the importance of vaccines and other measures like masks and social distancing.
Thank you. Thank you for inviting me. I'm going to share some slides of a talk I gave in Harlem about 6 weeks ago. So let me see if everyone can see the slides or not. Can you see my screen? Okay, great. I don't have any financial disclosures. Currently, today, there are 5 million total deaths, but significantly, there are 7.5 billion vaccine doses already administered across the planet. Now, locally, we can see the third row, which talks about the percentage change over the last 2 weeks. And you'll notice that they're all positives. In Essex County, it's over 80% increase. In Berkshire, 13. Bristol, 64. Franklin, 126. Number of deaths daily has basically tripled over the past month, and so we're now in Essex County. Two of our county members are dying a day. So since the Alpha variant became widespread in early 2021, the idea that the pandemic would end by eliminating COVID-19 has kind of faded. Instead, the most likely outcome is one in which virtually everyone has been vaccinated, infected, or both, and consequently severe COVID cases would become relatively rare and within the capacity of the healthcare system to handle. Delta makes that a virtual certainty. And I used to say that the quickest route toward not wearing a mask is getting a shot, but that was before Delta, unfortunately. We're in a race now, and the new variants making current vaccines less protective and the loss of healthcare workers due to exhaustion, reducing the capacity of the healthcare system to function is what we're dealing with now. And we're responding also to the need for newer vaccines. And I can talk about that in the question and answer. We'll skip this slide. Now, herd immunity, I'll say just two words. Even though a person may not have immunity for whatever reason, like a child, what we do is we surround them and insulate them from the virus by having everyone around them have immunity. And measles is one of the most transmissible agents that has a reproductive number of between 12 and 18, which means if you have 90% of the population immune, it'll halt the transmission. The Wuhan variant, the reproductive number was 2 to 3. And so you only needed 67% of the population to be vaccinated. That's not true with Delta. It has a reproductive number of 8 to 9, and therefore 90% of the people need to be vaccinated. So I'm going to skip the part about vaccine hesitancy and apathy. So when we talk about the Delta variant, it's now so globally dominant that it makes up 99.5% of all the variants, and the exception of South America, where there's still several others. It's 2 times more contagious as previous variants. It's more likely to infect people in the put infected people in the hospital than prior variants. Importantly, it can cause symptoms 3 days earlier than previous variants, giving the immune system less time to mount a defense. And people infected with Delta carry about 1,200 times more virus in their noses than previous versions of the virus. The amount of virus in vaccinated individuals and unvaccinated individuals is about the same. Both can transmit the virus to others. So some are going to ask, well, why get the vaccine? Well, that's an important question. In vaccinated people, the amount of virus drops more quickly. They spread the virus for a shorter period of time. And that's why you need that advantage. That's why you need to get vaccinated. It also decreases the severity of the disease, and it decreases the amount of death that is that we see. So the current vaccines don't prevent the infection. The virus is still capable of replicating in the nose of even the vaccinated, and it can still transmit disease through tiny aerosolized droplets. So if we're going to defeat this, we're going to need to require a new generation of vaccines that will probably also block transmission. And we're in a race because it's constantly mutating. The Delta variant has already mutated. They've got the new one, the AY4.2. It's already here in 42 other countries. But the key is we need to slow the pace of infections to catch up to the virus before it mutates into a version that allows it to pierce the immune protection of both natural immunity and vaccines. We're going to have to utilize our antibody infusions, our antibiotics. There's 2 new ones that are that have filed their EUAs, and we're going to have to continue the public health measures. So you have to think of the vaccine like the Star Trek deflector shields. And do you want to have a deflector shield or not? You're still going to face the Klingon bird of prey. It's still going to be firing stuff at you. And you're more likely to survive if you have the shield. So one of the reasons you have to think about that, but at the same time recognize that if you get hit by a photon torpedo or the phasers, in other words, if you get a large enough inoculation of the virus, it can overcome your deflector shields. You can get sick. You can end up in the hospital. So I'm going to skip these slides and just talk about the SARS-CoV-2 virus is real, can in many cases be very deadly. It's spread mainly through the air when people are in close proximity to each other and by not wearing a mask properly. Someone in the group is infected and is a carrier, and recognize that vaccines are safe and very effective in preventing serious illness and death. And there has been no vaccine in the history of mankind that's been more tested than these vaccines. 7 billion people have been vaccinated. So I'll talk about rampant individualism and, in the question and answer session, because that's a very important aspect of why some people don't want to get the vaccine. And I was told 5 minutes, so I'm going to try and stick to my my time limit.
Wow, that was impressive. And you threw in a Star Trek metaphor. Fantastic. Thank you. Dr. Rice, thank you. That was a great, great overview. And now we'll move on to Dr. Clovin Campbell. She's the MD Medical Director of the Pediatric Associates of Greater Salem and Beverly, to hear her thoughts on the pediatric side of this.
Good evening, everyone. Thank you for inviting me, and thank you, everyone who's attending. Okay, so I think everyone knows that at the start of the pandemic, very few children had cases of COVID. COVID in children represented only 2% of cases. But as of early November, that level was up to almost 17%. And there are different reasons for that. It's likely representing the fact that more adults and older people are getting vaccinated. Everyone is right. Very low hospitalization rates for children, 0.1 to 2% if you look at all the data. And very few children die of COVID, although in September there were something like 87 deaths for whatever reason. None in Massachusetts, thankfully, but very low rate of deaths in children. Next slide. More than 140,000 children in the United States and nearly 1,200 kids in Massachusetts have had lost a parent or grandparent caregiver during the 15 months of the early pandemic. This is a significant burden of loss. So although children themselves might not have had significant hospitalizations and death, the loss that they've experienced in terms of a parent or a grandparent caregiver was significant. Nearly 1/3 of children who lost a caregiver were Latinx, and just over 1 in 4 were Black. Nationally, coronavirus-related death of parent or grandparent caregivers were impacted by 1 in every 753 Caucasian children, comparatively 1 in 412 Latinx children, and 1 in 310 Black children, 1 in 168 American Indian and Alaska Native children. This is unfortunately a disproportionate affectation of children of color. The mental health effects on the COVID-19 pandemic on children is the other side of the pandemic that hit children significantly. The estimates, the prevalence estimates of clinically elevated child and adolescent depression and anxiety were 25% for depression and 20% for anxiety. And that compares to a pre-pandemic, about 13% prevalence of anxiety and depression. And honestly, I've seen that in my own practice. It was mind-blowing, the number of cases of anxiety and depression. In a single day, I might discuss depression, anxiety, and emotional health in every single patient that I saw. And that has improved with vaccination rates, actually. So yes, COVID-19 in children is often milder than in adults. Yes, the virus rarely causes deaths in children. Why are we recommending the vaccine for children? So in terms of the benefits for kids, vaccinations benefit the children themselves. Some kids can actually get severe lung infections and require hospitalization. And yes, rarely they may die. The Delta variant in particular has been so much more contagious than previous variants, and vaccines are very effective in preventing severe illness. You might get sick, but you won't get so sick that you end up in the hospital. The hospitalization, although you might have some vaccinated people, are really high level of unvaccinated persons. Children can also get a rare complication such as multi-system inflammatory syndrome in children. Usually appears about a month after COVID infection. That may require intensive care and cause long-lasting symptoms that affect their health and emotional well-being. In terms of the benefits for mental health, as I said, the significant pandemic in children in terms of their emotional health was it was quite shocking. And one of the things that I personally noticed is the improved social and emotional health in children as we increased our vaccination rates, especially in Massachusetts. We were keeping the children in school. That really improved their social health. Vaccinating also allows children to play with less disruption, increases their participation in sports clubs, going on school trips, and just seeing their friends. In terms of the benefit for friends and family, but also not just focusing on individual health, but the public health. There's something to be said for caring for each other. Children with COVID-19 can transmit the infection even when they have no symptoms. Getting vaccinated reduces the chance that they transmit the virus to others. Vaccinations just in general, as Dr. Rice said, reduces the virus's chance to mutate into new variants that may be even more dangerous. And vaccinations reduce severe infections overall, therefore reducing hospitalizations and death in susceptible people. I wanted to just say a word about the concerns regarding myocarditis in vaccinated children. Myocarditis has been rarely found, particularly in male teenagers and young adults, primarily athletes after the second dose of the mRNA vaccine. The symptoms reported are mild, including mild chest pain, pounding of the heart, fluttering. There have been no deaths in children due to the mRNA vaccine. In millions of doses of vaccine, billions administered, the cases are extremely rare, reportedly 16 cases per 1 million. The rate of myocarditis with actual COVID infection is 6 to 34 times more likely than you would get with the vaccine itself, and with more severe long-term symptoms of chest pain, shortness of breath, and hospitalization. And I will end there.
That was a great overview. And I think, two things that kind of stuck out was the disproportionate effect on children of color with the pandemic, and also that the vaccine rates had a positive impact on the youth. And the 16 per million is definitely different than what some people might, I think, believe out there. Before we move on to Dr. Faye Stern, I wanted to just recognize, I see Senator Bruce Tarr and his American flag there. Hello, Senator. Thank you for coming. Did you want to say hello for a minute before we moved on?
Good evening, Natalie, and thank you. And I do appreciate the opportunity to just say hello to everyone. I have been listening for a while, and I have really appreciated the information that's being provided. And it's good to see my friend, Dr. Stern, on the call and about to present as well. But I do want to thank you. I found the last two presentations extremely helpful in trying to put some of the things we hear around us into context. Around vaccination. And so I really appreciate the information that we've gotten so far, and I look forward to the remainder of the presentations. And I do want to say it's good to be in this meeting with my good friend and colleague, Senator Crichton, and he and I, along with our Senate colleagues, spent yesterday's formal session working on the topic of trying to ensure equity in mental health, which is a major subject for the Commonwealth of Massachusetts. And I think we produced an outstanding bill working together in a collaborative, bipartisan way. And perhaps, Natalie, at some point we could share that information with you in this format as well. I think you might find it both interesting and helpful. But for right now, just thank you for inviting me into the conversation. I'm pleased to be here.
Thanks for being here. And now on to Dr. Faye Stern, who will provide an overview of the importance of prevention and early detection of COVID and prostate cancer. We'll move into that part of the conversation as means of improving patient outcomes and reducing health disparities.
Thank you so much, Natalie. Thank you for your partnership. I cannot miss an opportunity to express my gratitude to legislators, Senator Tarr, Senator Kreiter, Senator Lovely, for their years and years of support for our program that makes events like tonight possible. Thank you so much. I also would like to acknowledge my staff, Thomas Satam and Ali Adam, who are actually taking care of everything related to this event, including technical management. Thank you so much, guys. I actually pre-recorded my remarks, and in order to avoid any kind of internet problems. And Ali, is it possible to play my pre-recorded video? I'd like to express my gratitude to North Shore Naacp and President Natalie Bowers for the opportunity to address prostate cancer awareness in the times of the COVID pandemic. This event is a part of the AdMeTech Foundation ongoing program in prostate cancer awareness and education in Massachusetts, with primary focus on high-risk men, including African American, Hispanic, and Latino individuals. Our program was initiated in 2014 with strong support from the North Shore delegation to the state legislature, particularly Senators John Lovely and Brendan Crichton. I'd like to thank Drs. Clovin Campbell, Philip Price, and Stephen Zappala for their participation in this event. Both COVID-19 and prostate cancer have emerged as leading health disparities in Black and Hispanic communities. In April last year, early in the pandemic, we have recognized that the areas of prostate health disparities directly overlap with the pandemic hotspots. Since May 2020, we have expanded our program to include education about COVID-19 as reflected in this event. Prevention and early detection are critical for saving lives and eliminating disparities in both prostate cancer and COVID. The future of this pandemic depends on us. We can drive down infections drastically by wearing masks, particularly indoors or in crowded outdoor settings. We can end this pandemic by complying with vaccinations. Masks are the best tool we have for preventing spread of infection. If most of us wear masks, we can flatten this pandemic, prevent countless infections, and save at least 1,000 lives in our state by March 1. Vaccines are the best tool we have for ending this pandemic. In mid-September, CDC reported that in fully vaccinated people, infections were reduced more than 5 times, with hospitalization and death reduced over 10 times. Many experts pointed out that the vaccines could have prevented over 97% hospitalization and death we have seen over the last few months in individuals aged 12 and over. Since early last year, more than 5 million children were diagnosed with COVID. By the first week of September, new COVID cases in kids reached record levels. We are excited that 2 weeks ago, COVID vaccines have become available to children aged 5 to 11. In the interim, our masks and vaccinations can protect children of all ages and their in-person education. On September 14, Boston Globe journalist Renee Graham wrote an opinion, "The Unvaccinated and the Orphans They Leave Behind." Over 120,000 kids lost their parents or caregivers to COVID in this country, with Black kids impacted disproportionately. She raised an important question. Can we allow our hesitancy of the COVID vaccines define our children's future? On July 27, U.S. Surgeon General Dr. Vivek Murthy shared publicly that he lost 10 members of his family to COVID. He pointed out masks help us reduce spread of infection, while vaccinations remain the key to ending this pandemic. While we are dealing with the pandemic, prostate cancer cannot wait. And yet many men avoid visits to their doctors out of understandable fear of contracting coronavirus. Unfortunately, delays in prostate cancer care can cause reduced quality of life and even loss of life. Clinical facilities created a safe environment for patient care, including virtual visits and telehealth, ongoing in-person care, such as physicians' appointments and testing, and medical procedures, including biopsies and treatment. Ongoing care is particularly important for Black, including Hispanic men, who are 2.5 times more likely to die compared to white men. However, early detection saves lives and eliminates health disparities. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast, with late diagnosis, when cancer is spread to other organs, only about 28% of men remain alive at the same time. In prostate cancer, screening with blood tests called PSA is the best tool we have for prevention and early detection, critical for saving lives and reducing health disparities. During pandemic, it is more important than ever to take charge of your prostate health. It is important to know your risk factors, such as African heritage, family history of prostate cancer, particularly brother or father, and increasing age, 50 and older. You can ensure early detection during annual visit. Ask your doctor about PSA blood test and digital rectal exam. You need to talk to your doctor starting at the age of 40 if you have risk factors, or at the age of 45 if you do not have risk factors. Before screening, it is important to avoid exercise or sex, which may impact your testing results for 1 week. After screening, you need to ask your doctor if your test is normal or if you need a referral to a prostate cancer expert. In late September, AdMeTech Foundation held a virtual annual global summit on precision diagnosis and treatment of prostate cancer. Our summit brought together the key international experts to educate medical community and general public about the cutting-edge advances in screening, diagnosis, and treatment. Screening of prostate cancer with PSA blood test reduced death by more than 50% and has been more successful than many other established cancer screening programs. In men before diagnosis of prostate cancer, we have seen rapid advances in accurate, non-invasive testing, which created a new standard of care, including blood and urine tests for molecular markers and imaging tools such as MRI. These tests improve identification of men who need to undergo biopsies and eliminate many unnecessary procedures. In this slide, MRI shows prostate cancer lesions and guides biopsy needles with precision. Our summit highlighted the importance of MRI in Black men who are likely to have lesions in the front part of the prostate that are difficult to find by physical exam or standard biopsies done without imaging. Our summit also highlighted the importance of assessing genetic predisposition to aggressive, potentially lethal prostate cancer. Testing for genetic mutations is particularly relevant for men with family history of aggressive prostate cancer and other malignancies. In men with prostate cancer, there are 2 pillars of the current diagnostics, MRI and genetics. While MRI shows cancer location and spread or stage, genetic tissue analysis reveals underlying cancer biology and probability of progression. With these precision diagnostics, we can now accurately determine if each individual has a slow-growing, harmless prostate cancer and needs only careful observation, or aggressive type of prostate cancer requiring immediate life-saving treatment. Recent studies in veteran administration and military medicine showed that with equal access to prostate cancer care, there were equal patient outcomes, including equal probability of death in Black and white men. Based on this and similar evidence, our summit concluded that access to care is the key factor in eliminating health disparities. We recently expanded our community education to include a program for improving access of high-risk men, particularly African American and Hispanic individuals, to high-quality clinical care. We have been working with men to match their individual needs with leading state experts in prostate cancer care who have the most advanced screening, diagnostic, and therapeutic resources available today. Our clinical care equity program is open to any high-risk man who is interested in consulting a prostate cancer expert to address every aspect of their prostate health. This consultation may include an initial evaluation or a second opinion, virtual or in-person visit. You will benefit from this program if you're not sure screening is right for you and seeking more information. If you had screening already that raised questions about your results and the appropriate next steps. If you were recommended an invasive biopsy and seeking more information about the related options in order to make an informed decision. If you have family history of prostate cancer and have questions about genetic testing or counseling. If you were diagnosed with prostate cancer and would like to learn more about treatment options. If you experience complications after biopsy or treatment. If after treatment you have questions about the next steps, including prevention or early diagnosis of cancer return or progression. Summer Mills, a member of our staff, serves as a statewide clinical coordinator. If you have any questions, please contact Summer by phone 617-523-3535 or by email Equity Project Coordinator at AdMeTechFoundation.org. In summary, prevention and early detection and related public awareness and education save lives and reduce health disparities in both COVID and prostate cancer. Masks and vaccinations prevent COVID infections, hospitalization, and death. Advances in screening and diagnosis created a precision, individualized approach to prostate cancer care. Thank you for your attention.
Great. Thank you for that, Dr. Stern. I kept on looking at you like, why is her lips not moving? I think I want to say, before we introduce Dr. Zappala to carry on about the emerging advances in the treatment of prostate cancer, I think if you're of a younger age, you sort of look at discussions about prostate cancer like, why do I even want to talk about this, right? But the reality is that it really is a prevalent disease. And Dr. Zappala, he is the MD Clinical Assistant Professor at the Department of Urology at Tufts University School of Medicine.
Good evening. Welcome. I'm going to try to share my desktop if I can. Let's see if it works. Natalie, thank you, and Faye, and thank to the whole team for organizing. I've learned so much this evening. I want to thank everyone, but I was given a kind of a huge task to talk about the current treatments of prostate cancer, all within 5 minutes. And this is going to be what a chore. But when you start thinking about prostate cancer, Natalie, just the way you described, you think of it as a disease of my father or my grandfather. And if this slide looks confusing, that's exactly the indication, because it is very confusing to physicians, to urologists, and more importantly, to patients. We're using words and we throw them around, and we have so many different options today that we don't really have a clear road ahead of us. And I think, fortunately, with new technological advances, we are making it a little bit easier. I just wanted to show couple slides that was touched on why we're here this evening. And this looks at race and looks at incidence and mortality. But if you look at the second line, the African-American subset, as we know, they're twice as common to be diagnosed with prostate cancer. But look at the far right. They're twice, more than 2.5 times more likely to die of the disease. But I think what's most important, if you look at this recent data that was put out from MD Anderson in Texas, this looks at different Black, white, Hispanic, Asian. But if you look at the African-American subset, which is the top line, we know they have a higher incidence. But what I find astonishing, and why I want to reinforce what Faye said about early detection, look where the diagnoses begin at a very young age. And now the way you described, this isn't a disease of my grandfather, it's a disease of our children and of our friends. So when you look at the average risk, we start telling a man, get a PSA at age 50, which is a simple blood test. But if you look at what the American Cancer Society says, men for high risk, begin this at age 45. And what I find kind of confusing is that the AUA will say age 55 and the National Cancer Society will say, let's try it at age 50. But we begin in our practice screening African-American men with the baseline PSA at age 40, and then they start annual screening at age 45. But what does it involve? Because I think screening leads to early detection, and early detection leads to the advances that we have as surgeons. You have to get a blood test called a PSA, as Faye described. It's an enzyme only made by the prostate gland. It's detected in the blood. It's a very simple blood test. Whenever you see a blue glove, it's not a good sign. That's a digital rectal examination. And we palpate the prostate, which is about the size of a walnut and the texture of bread dough. And
I think we lost Steve, but I'm sure he will rejoin us in a minute. Natalie, can I have your permission to ask a question of Dr. Campbell and of Dr. Rice?
Please, absolutely.
Great. Dr. Rice, very frequently, as you know, and Dr. Campbell, of course, know the same thing, very frequently we make our decisions and we make our recommendations based on what we will or will not recommend to our families as physicians. Would you recommend for your family members, including young family members, to get vaccinated?
So I could, Dr. Rice, let me speak. So I have two children. My son got his first dose of the Pfizer vaccine when he was 12 years old, and he got his second dose on his birthday. So got an extra donut, but I'm sorry, Dr. Zavala, are you back now?
Yeah. But if you do not mind.
So my point is that's one of the first things I share with families is that my own children are vaccinated, and that I myself had side effects after both vaccines, but I'm still standing, and I'm very thankful that I had the vaccine, and I also got a booster as well. So I think that it's important that we share that we vaccinated our children. My own mother was vaccine hesitant, and I talked to her about it and talked to her about why she was concerned about it, and ultimately she got vaccinated. And so talking to our friends and family is very helpful, but my own children are vaccinated.
Thank you so much. Thank you. Steve, we got you back. Last time we heard was that prostate was a walnut-sized gland.
Yeah, and I always tell a funny story about this. We practice in Andover, and we tell men they have to come in for a digital rectal examination. And these engineers come in, and they're confused. They're looking for some type of a computer printout. And when I tell them, no, I have to do a digital examination of your prostate, they become frightened to death, and they begin to perspire. So that's why I always tell everybody it's early detection with a digital exam and a PSA. Because if you catch the disease early, you have many, many options, including active surveillance, or having the prostate removed, or some type of radiation therapy. But as you get more advanced, as you go further down the line, and we're seeing this with COVID, people are not coming in for PSA screening. They're delaying the onset of the urologic exam. They're far beyond active surveillance. They're getting far beyond the prostatectomy. We're looking at chemotherapeutic regimens. So that digital rectal examination is very, very important. And I tell a lot of men when I see them in the office, I have good news and I have bad news about your prostate cancer. The good news is that we detected the prostate cancer very early, and we have several treatment options. And they look at me and say, well, what's the bad news? Well, the bad news is we caught your prostate cancer very early, and you have several treatment options. Patients get confused, and we have to now go to individualized medicine, to personalized medicine, say, what's best for you? We cannot have one size fits all, and we can't use that same golf club for every hole in the golf course. We look at patients' chronologic age and their physiologic age, and I think it's most important if we find out what are their expectations. So if you look at options for prostate cancer, clearly the top of the line is active surveillance, and it is active surveillance. These men are coming in every 6 months for a PSA, getting a follow-up MRI, and getting repeat biopsies. But more importantly, I put them on a low saturated fat diet. I ask them to watch their calcium and their vitamin D, and to begin an anaerobic metabolism program. They can choose radiation therapy, which could either be external beam, or we can place radioactive iodine pellets. We call it seeds, which is brachytherapy. I just want to take a moment and talk about surgical removal. I have some experience. And the prostate can be removed either with a Da Vinci robot, a laparoscopic technique, or traditional techniques. If we do a traditional technique, we take the incision from the symphysis pubis all the way up to the umbilicus to the belly button, and we split the rectus bellies, and that's how we do the procedure, which takes approximately 2 hours, and you're hospitalized for 48 hours. Robotic surgery is totally different. We use anywhere from 5 to 6 robotic ports, and these ports allow access to the abdomen, and patients are hospitalized routinely for one night, and their activities to return to activities of daily living and to return to work are much shorter. Here, I'm kind of obscured, you can see a patient, the foot is at the bottom of the slide. You can actually see the robotic ports all inserted. And these will all now be attached to cameras and to the robotic arms to watch how it works. And I just wanted to show this slide to show how busy it is in the operating room when we use the robot. Here's the patient lying. His head is way up here. Anesthesia is up here. You can see the ports here with the assistants using the suction apparatus. But look how much staff is here. Now, the surgeon is all the way over here. The surgeon is seated. He's wearing in his hands a set of gloves, or these, I call them Wii's. And when you put your face inside the console, all of a sudden you get a 3D image of the entire thing. So this is not a robot that you see in Detroit. Rather, it's a tactile guided robot where we actually guide the device. Here's some of the imaging. Here's you can see the robotic picture there with dissecting off. But here we're using the robot to guide those limbs that are doing all of the work. And this has made a tremendous difference in how quickly patients can leave the hospital. Blood loss should be negligible. And the pain, most patients never leave, even taking Percocet therapy. I just wanted to mention a couple things. If we capture the cancer early enough, we have a lot of new minimally invasive, I call it focal therapies. High intensity focused ultrasound can be treated transrectal with the robot. We have a transurethral ultrasound. And we also have laser ablation now, which can be done just about in an ambulatory setting. This is completely outpatient, it's quick, and you lack all the significant risks or complications as discussed. I say as a surgeon, we have 3 primary objectives when we go into that operating room, the 3 C's. And that's all you have to remember. I tell my patients, my goal primarily, it's a cancer operation. We must remove the cancer. Secondarily, as we go down that list, it's continence, it's bladder control. So while you're there removing the cancer, please keep away from the sphincter, which is located at the bottom of the prostate, that allows the voluntary control of the urinary bladder. And finally, in that progression, the cavernosal nerves, these very delicate nerves that run along the sides of the prostate, these govern the quality of the penile erection. But we don't spare the nerves and leave cancer behind. It's a cancer operation first. Guarantee bladder control. And if you're there, try to preserve those nerves. What I did was also want to introduce the 4K score test. A lot of people get frightened about surgery. And the 4K score is a blood test, a very simple blood test, but the results are given as a percent probability. What's the percent probability this patient has the aggressive subtype of prostate cancer? Again, a simple blood test measuring 4 types of PSA. We showed in a large community practice group about over 600 patients that we were able to reduce prostate biopsies by over 45% based on risk. Again, using risk as the predicate. Why should you have a biopsy? And we went the next step, and we looked at African American men in this large subset. And this was done with Sonoj Poonen at the University of Miami. And we wanted to say, how does this 4K score test specifically work in the African American subset? And the population we used was at the veterans hospitals across America. And if you go to the bottom of the slide, the AUC, the area under the curve, and that's the statistical percentage, was just as effective between African American men and non-African American. So now we have a blood test that can actually reduce prostate biopsies and actually give all types of men a predictive model, a risk stratification tool. Should you have a biopsy or not? What's my risk of having the aggressive form of prostate cancer? So to summarize everything I've said, if you go to the left of this slide, that's what we want to get. With early detection and early diagnosis, we have all the options available, from surgical removal of the prostate to radiation therapy to active surveillance. But if people start coming in too late because of fear of the exam, fear of the unknown, lack of access to quality care, we're diagnosing them too late. And if they're too late, they're bound to a regimen of either hormonal therapy or chemotherapy. Finally, I like to tell people we have to all work together. Here's a great example of a whole series of hands. I always say it's great to have inspiration, but we need perspiration. And if you look at this is the things kids always do, making a heart. But if you look very carefully, you can see the faces of two people, because that's what prostate cancer is all about. It's about people. We could talk about statistics and models and percentages, but it's about people. And that's what we really need to help. So I think by working with community organizations like the NAACP or AdMeTech, getting physicians more involved with racial disparities in prostate cancer screening, and finally getting the government involved, we can really make an effort between early detection and getting men for cure. And I've always said we can actually look at this as calling it the National Associations of Advocates for Cancer of the Prostate Screening. I think that would be a great thing. Thank you very much.
Thank you, Dr. Zapala. Wow. Definitely learning some things here. The 3 C's.
That's right.
Such a shame. That concludes our speaking and our presentations. And now at this point, I just to sort of clarify ending of this session, we did advertise for 8, but I do think that we're probably willing to go over a little bit, especially if we get questions. I, at this point, would like to turn the Q&A portion of tonight over to Dr. Faye Stern, who will moderate public discussion about the questions on COVID and prostate cancer. Thank you, Dr. Stern.
Back to Dr. Rice. Dr. Rice, if you would like to leave our audience with one take-home point, as an emergency physician taking care of COVID patients essentially on an everyday basis, what would be the point you would like to highlight?
At this stage, there are 2 points, unfortunately. But the 2 points are wear the mask and get vaccinated. Those are the 2 most important things that any individual can do on this planet.
Thank you so much. Dr. Campbell, what would be your recommendation for highlighting a take-home point for our audience?
So I would reiterate what Dr. Rice said. I think that sure, we would like to get to a time when we're not wearing a mask, but frankly, I'm comfortable moving on with my life. I love to eat out, and I think that wearing a mask and getting vaccinated are the 2 things we can do to just to get on with our lives, frankly.
Thank you very much. Dr. Zapala, if a man is referred to you by his doctor with concerns related to screening results, would you recommend non-invasive diagnostics such as a blood or urine test for molecular markers like 4K score or MRI before invasive biopsy?
It's a great question that comes up each and every day. And the answer is both. I think we're using now them in conjunction. Years ago, if you had a high blood sugar, Faye, you were on insulin, but if you had an abnormal EKG, we didn't push you on to go to get bypass grafting. And today, if you have a suspicious PSA, we don't go to biopsy. Rather, we go to either a biomarker panel, urinary or blood-based, or if you want to use a multiparametric MRI, if it's available in your community. But I think the days of going straight from PSA onto immediate biopsy, that got us in trouble with overdiagnosis and overtreatment. And now we're getting more specific with biopsying those men who would really benefit from the disease itself.
Thank you so much, Steve. And once again, Steve, before I will ask you the last question, do you have any questions for other panelists, for me, for Dr. Rice, Dr. Campbell?
Well, I just wanted to thank Dr. Rice and Dr. Campbell. I thought it was fascinating. I learned more about COVID this evening than in the past 2 years. But Dr. Rice, one question is, we've seen patients still expressing apprehensions to coming into an outpatient area because of COVID. And they're saying, do I really need to wear the mask if I'm just coming into the exam room? What are your thoughts? I mean, if they're just in an exam room, they're frightened. Yes or no?
Yeah, I think that it's smart to wear a mask if you're around other people that you don't know that aren't within your bubble. I think that the reason is that we have a virus that is, very, very infectious. It's not the same virus that even the vaccine was designed around. In other words, the vaccine was designed around the alpha variant. And where we took the instruction for the structure of the spike protein, the construction plan for it, and we made an mRNA virus, mRNA molecule and wrapped it in some oil, and that's what we inject in folks in order so that it'll produce the spike protein that your body will then begin to recognize, both your T cell, which not many people speak about, but also your antibodies. So you need both to actually get immunity. And what they are talking about now is now taking the Delta variant and its construction plan and putting that into another type of mRNA vaccine. And we can do that pretty quickly. It's just hard to do it profitably if you're going to keep switching in and out the mRNAs. But if they come into a room and everybody's vaccinated, I would still, if I don't know them and they're not in my bubble, I would still go ahead and wear them.
Excellent. And Dr. Campbell, I'm 50% of my practice is pediatric surgery. What about children undergoing surgery? We're still asking the parents to get an RT-PCR assay on the children. Is that consistent with your thoughts?
Yes, I think that some of the struggles that our pediatric patients have had, though, is after they have had a positive test, some of the facilities, for example, require a negative test
Correct.
to do their routine surgeries, and they might be positive for quite some time. So it's I think it's not based in science, but that's my own person. So I write them letters. But they also, when children are coughing and have a fever, and we've tested them for COVID, there are some facilities who will not do their chest X-ray. So there's a little bit of struggle going on.
Get it? Okay.
Thank you so much. Dr. Rice, may I also ask one more question of you? When you are looking at the risk of vaccines vis-a-vis risks of COVID, would you like to comment on that?
Yeah, so the risk of the vaccines, and one of my first slides kind of showed that over 7.5 billion people have received vaccines. And a very, very minuscule number have had any kind of reaction towards them. And the risk of the vaccine is very small. The risk of COVID getting the same reactions that tiny minority has is 16 times worse, if not sometimes 100-fold, depending upon the adverse reaction that you're talking about. And so if you're worried about myocarditis, you need to worry about the virus, not the vaccine. And that's what the take-home point is that all these things that people are throwing up into the air for smoke about why they don't want to get the vaccine, the fact of the matter is there are lots of reasons not to get the vaccine, but there are no good reasons not to get it. So get the vaccine because you're more likely to have worse problems getting this disease. And this disease is not one to play around with.
Thank you very much. Senator Tarr, do you have any questions for any of the speakers?
Well, thank you, Dr. Stern. I actually hope you're not going to regret that you asked that question. I actually have 3 questions, and I'm not sure if you'd like me to pose them one at a time.
Absolutely, yeah. Please,
Okay.
one at a time. Yeah.
So first of all, I hope you all will indulge me because with this much medical expertise, I cannot risk not taking advantage of it. So my first question is one that comes to us often as policymakers when we talk about protocols for mandates. So for instance, the Senate is mandated, the members and the staff are mandated to get vaccinated. But in that context, once in a while, someone will say that we need to make sure we provide a medical exception. And I'm curious, because when folks ask me if they're questioning whether or not they should get the vaccine, my first answer is talk to your doctor. You trust them with every aspect of your health care, and your PCP or a relevant specialist should be the person you consult if you have a question about the advisability of the vaccine. But I'm curious, and maybe this is a naive question, but are there medical conditions or predispositions where the vaccine would be contraindicated that maybe you could help to shed some light on?
Dr. Rice, would you like to comment?
Yeah, I think there's typically only one. There's some of the vaccines have ethylene glycol in them, and some people have an allergy to that particular molecule. And so because of that, we don't advise those particular vaccines. However, there are other vaccines that you can use that do not have that in it. And so even though you may have an allergy to one of the components in a couple of the vaccines, there are other vaccines that are also available.
Thank you, doctor. That's extremely helpful. And I'm assuming that component is a medium in which the active ingredient is transmitted or suspended.
You're absolutely correct. It's used inside a little fat globule to protect the mRNA, because mRNA has been around since the 1990s, and every time they tried to inject it, the body would just knock it off as soon as it got in. So the question was, how do you get the mRNA inside the cell? And so it was only when they came up with that combination, and that's what Pfizer and Moderna are so, avidly protecting that knowledge. How do you do that? That's what the key is. So if you're allergic to that, you don't get those.
It's unusual. It's unusual though to have an allergy. The active ingredient is also in Miralax, which is a laxative. Very few people. It's rare that people have an allergy to that.
So that's extremely helpful, and I can't tell you how valuable it is to understand that, because on a routine basis we are presented with arguments about medical necessity of not having of the vaccination. So it's extremely helpful. We also are confronted routinely with issues of religious exceptions, but this is not the forum for that. But I just wanted you all to be aware that we hear about those things quite a bit. So if I might, Dr. Stern, my second question relates more to the evolution of the vaccine. And Dr. Rice, you alluded to this a little bit. And I'm wondering, looking forward, do we foresee a time where we can know the frequency that will be required for the vaccine? I know that there's been a lot of discussion of the efficacy of the two-dose regimen now requiring the booster to maintain antigenic presence in the body. So I'm curious, do we think, or do all of you think, that we are going to be looking eventually at a situation where an annual vaccination is required? Might it be more frequent than that? Might it need to change with a degree of fluidity based on variations that will develop as this virus spreads throughout the population and mutates?
Dr. Campbell, would you like to address this question?
I don't think we know. I think I think it's something, as we get more real world data, that we'll have to figure this out. I think Dr. Rice's slide spoke to the fact that we have to have a better vaccine that actually prevents the virus. For us to really beat down this virus, we really need a vaccine that actually prevents us contracting the virus, which this vaccine doesn't do. So I don't think we know if we're going to need boosters recurrently the way we do for the flu vaccine, and of course you have to predict the strain of the flu shot, of the prevailing flu strains and that sort of thing when they're creating the vaccine each season for the flu shot. But I think that if most of us vaccinate, then we will have very few opportunities for the virus to mutate. I think that's the key.
Thank you very much. Senator Tarr, do you have one more question?
I do. Thank you, Doctor. And my last question has a little bit more immediacy to it, and that is to try to get thoughts from our panel relative to the likelihood that we're going to see a continued surge in cases. We seem to be seeing that right now with the return of cold weather and the aggregation of folks inside warm spaces, which seem to be the most fertile environment for the transmission of COVID-19. And I'm wondering, do you all have thoughts about whether it's likely that we are going to see a significant increase as time goes by? And the reason that I ask that question is because my assumption, if you asked me 6 months ago, would have been that our nation-leading rates of vaccination will prevent that from happening. But we are seeing breakthrough cases, and we seem to be seeing a significant number of breakthrough cases. And by the way, I did love the Star Trek analogy with the shields. It was wonderful. But I'm just wondering the thoughts of the collective wisdom on this panel relative to what we might see, let's say between now and January 1st, as we return in New England to that season where we're all inside, particularly over the holidays. Are we likely to see a significant surge, or will our level of vaccination present a barrier and a protection against that kind of a surge?
Senator Tarr, medical forecasting is a complicated business. And yet, if I were to choose one medical forecaster in this country that I truly trust, it will be University of Washington. And their predictions have been so much on mark during the entire epidemic. There is another advantage of this group. They actually project longer term than other group, which is even more complicated. The bottom line is that they predict continuous rise in cases in Massachusetts up until about late September, early November, when cases will reach their peak. And then there will be slow rise. So their prediction period, their core forecasting period right now is until March 1. And until March 1, we see a peak in cases in Massachusetts at around late January, early February, and then very slow decline. So we are looking at a tough season, according to their best predictions right now. However, it can change depending, or particularly, it's very difficult to impact rate of vaccinations right now, but this can change drastically depending on the level of mask utilization. If we get to mask utilization, which is called universal 95% of the population, we will flatten this pandemic in Massachusetts and nationally, according to their prediction. And their prediction takes into account a level of vaccination and every imaginable factor, social distancing and everywhere. And they are very worried about any further relaxation of mask requirements in Massachusetts. And we may, if there will be any further relaxation in requirements of masks, we may be facing a wave that may be bigger than with what we had seen last winter. It can be quite overwhelming. Yeah.
So
together.
As difficult as it is to hear about that possibility, it's critically important to hear it and to be able to think about that, particularly as folks have developed what we often refer to as COVID fatigue, where they would like to not wear a mask any longer. I mean, to hear the continuing relevance of masks and the importance of masks is important.
Critical. Universal mask, when most people wear masks, literally flattens the pandemic. And I think that for some reason, public health experts, as much as we are trying to communicate this message, it just doesn't seem to land. And it's very frustrating to see so much relaxation in terms of mask requirements. Social distancing, it's understandable. It's mental health. It is economy. It's so much. But wearing masks does not have any risk associated with that to society or to individuals, actually. And universal mask, 95% level of getting close, literally will flatten this pandemic. In Massachusetts alone, the difference in daily infection with universal mask vis-a-vis current level of compliance, which is about 30%, 35%, is the difference of daily infection of several hundred to several thousand.
If I
Alone.
may.
Okay. Dr. Rice, would you like to comment?
I was just going to say that when we talk about the masks, et cetera, and the battles that we're seeing, we get into the political aspects of it because it's become a badge, and we've got a very divided country, half and half almost. But you're not going to see the virus stopped in its tracks because it has a reproductive quotient of 9, and because of that, you need 90% of the population to be vaccinated. Given our state of our country, that's most likely not going to happen, and you're not going to get everybody to wear masks. The key and strategy that I think that's going to happen is you're going to have to develop tools that allow you to flatten the curve without that. That means deal with and save lives even if they're hospitalized, because someone's yet to show me that President Trump and ex-President Trump and some of the cronies, et cetera, that have promoted these no masks, the Florida governor, Abbott in Texas, are they going to turn around? No, they have a political objective. And I think we have to all be clear about that. And actually, that's what a lot of my other slides were about. We didn't need to get into that here. I wanted to speak more technical. But that's what I'm thinking. Is yes, we are going to see a big surge. And in the emergency department, we are already preparing for it.
Dr. Rice, do you guys have the Pfizer pill at Salem Hospital?
No, we do not. I don't think it's not been approved yet.
Okay.
It's not expected. It's not expected to be available until December.
Yeah, Merck applied first for EUA, and the molnupiravir is their pill, and we're waiting for Pfizer to get also approved. Hopefully, they will be in the next several weeks because the data is pretty strong. I looked at the data on both of them. The Pfizer pill is a double pill. It includes a HIV pill that we well know, ritonavir, along with a new chemical that will stop the virus from replicating. So I think that has lots of potential, and we would love to have it. And I also wrote the committee that governs Pfizer to get an IV preparation for it.
And Senator Tarr, I completely agree with Dr. Rice that it's not a realistic expectation to have 95% mask utilization, but I think educational messaging about the difference in cases, daily cases, or the difference to pandemic flatness with mask must be very high on everyone's list. People need to understand about the difference in daily cases, the difference in death with mask, particularly right now when mask requirements are relaxed, and we may be facing not only COVID but also flu. So I am really concerned because we may get a double whammy this winter, something we did not get last winter for our health system. And I cannot emphasize the importance of masks and the importance of staying away from politicization or encouraging what Dr. Rice mentioned as rampant individualism in this country. And basically to let people know, to keep on educational messaging alive about the difference in death and daily infections and our ability to get back to normal life or semblance of it with mask and vaccinations. Okay?
So I just want to say thank you. I didn't mean to monopolize the conversation, but I couldn't resist with this much expertise asking. I really appreciate the information. I would ask Dr. Stern if you could share with me offline. I know you have my email address.
Sure.
a place where I can look at the forecasting resource that
You'll
you
be happy
mentioned.
to.
And I would thank you. And I just make the observation that wearing a mask not only prevents the spread of COVID-19, but my understanding is it has a very positive impact on preventing the spread of influenza. And so it's a 2-for-1.
Yeah, so our entire season of flu, we had 0 flu cases until April when the mask mandate was lifted, actually.
Yeah. So this is extremely important. And actually, Senator Tarr, given your leadership position in Massachusetts Senate, I cannot say thank you enough for your questions and the opportunity for us to actually provide information that may impact public health policy. And I know that you are very quick in turning your knowledge into policy. So thank you so much for your presence. Thank you so much for your questions.
Well, thank you. And I wouldn't be here if Natalie hadn't invited me into the conversation. So thank you.
Thank you very much. Steve, getting back, by the way, Natalie, how much time do we have left? How much time do you allow us to have?
Yeah, really, I think 8:30 is probably good. There were 2 people that typed into the chat that they had questions. Lauren has a question and the Daily Item has a question. I don't know. It's up to you how you want to acknowledge that.
Okay. Lauren, do you want to formulate your question?
Yes, and I'll paste it in the chat for anyone hard of hearing. I'm thinking specifically of trans women who often have barriers to healthcare, just like BIPOC populations have barriers. There are more barriers, especially BIPOC trans women who anatomically have a prostate but may not be able to comfortably access healthcare as much. It's so important we have these discussions more publicly and talk to our family members, friends, colleagues about get the PSA blood test, follow up with a urologist if there's any suspicion of, and if you're anywhere near the ages of, risk for prostate care. I do have a question about how much more risk trans women have, or BIPOC trans women specifically, for prostate cancer, especially the ones who have hormone therapy. So limited access to healthcare is a factor that varies, but taking hormone therapy for, like your secondary sex characteristics increases your likelihood for getting many cancers. How does that affect prostate cancer?
Steve, do you want to address this question?
Yeah, it's a fascinating question. Actually, I just had to look it up a few months ago. When you look at the way we treat metastatic prostate cancer, Huggins and Hodges won the Nobel Prize in 1944 by showing that treating men with advanced prostate cancer with estrogen made their prostate cancer involute and disappear. And that was a panacea. And we're still using that today with a drug called Lupron. Lupron is a drug that we inject. It's an LHRH agonist. It works in your pituitary gland. It shuts off the stimulus to the testosterone production. Well, this sounds great. But what about a trans who's now taking estrogen? They've suppressed their prostate from expanding, and they may not have prostate symptoms when they get to be age 45, 55, or older. But when they do develop prostate cancer, they tend to get the aggressive type because they're not expressing PSA because of the estrogen. They're not getting access to care. No one's thinking about the digital rectal examination. Right before I got cut off, I was saying the prostate should be the size of a walnut. The one I saw with prostate cancer had the prostate the size of a small acorn, but the tumor still lives there. So it's a very difficult situation, but we have to use all the parameters. So I would throw everything at anyone who's even suspicious, but don't wait for blood in the urine and don't wait for obstructive voiding symptoms. You may have to rely on PSA. You may have to rely on all the other biomarkers, but PSA may not be. So don't think of the absolute value, but the velocity of change. In all patients, PSA should rise 1 to 3% per year, but if it jumps by 20% or more, even if you're in the normal range, that should open your eyes. Maybe something is going on.
Lauren,
did
Dr. Zappala address your question? Okay.
I think so, and I think it's so important to have trans-inclusive and culturally responsive healthcare. Thank you for the overlap here and all the work you're all doing.
Thank you so much. I think we had one more question that was typed.
Yeah, hi, that was me.
There was actually two. There was Daily Item and David Crowley. Sorry, Daily Item.
Hi, Sophie Yaron, by the way. I'm the deputy
Hi.
editor of the Daily Item. Thank you so much, folks, for hosting this extremely informative, very important work that you're all doing. Can't wait to write about it. My question is extremely general, and it's actually for Natalie. I'm just wondering where interested folks may be able to get a recording of this panel and when we might be able to access that.
Thank you, Sophie.
Actually, we will have this event alive, the entire video alive on our Facebook page. And Thomas, if you do not mind sending our Facebook link to everyone on Zoom, it would be very much appreciated. We also will have a newsletter. It will be a little bit of a cleaned up video, but video will be available immediately on our Facebook, and Thomas will provide this information through chat. And Mr. Crowley, you had a question.
Hi, yes. Thanks, everyone, for the great conversation. I'm David Crowley from nonprofit organization Social Capital, Inc. We're working on a vaccine equity project, and I connected with Natalie about it, and she invited me to this event, so thank you, Natalie. Actually, I sort of have it's more of a statement, would love to get some reactions and thoughts about this. And it seems like I know through much of the pandemic, I'm probably not the only one that get those daily alerts of how many new cases there are in Massachusetts, and it stresses you out when it starts getting higher as it goes up and down. And at the end of the day, it seems like the vaccines are intended not to necessarily stop, from getting any positive tests, but to keep folks out of the hospital and worse. So I'm just kind of wondering, I sort of feel like maybe that we need to focus a little more on those severe outcomes as sort of the headlines or the subject lines of the email. So I don't know if people have any thoughts on how to get people a little more focused on, those more serious outcomes and how to prevent those. And, do we need to show the hospital, the ICU, how full they are as something we look at more closely, kind of changing the metrics we look at a little bit. Any thoughts on that?
Dr. Rice, do you mind addressing the question? I also want to add to Mr. Crowley's question, something that was raised before this event. Somebody was a bit dismissive and was wondering why we are paying so much attention to severe COVID outcomes in COVID when we are focusing on COVID vaccines, for example. Is it the right metric in your judgment?
So, I think that there are a number of things that we need to look at, and the state website actually does, kind of gauge, tell everybody, how much this is affecting people in terms of especially the death rate. What it doesn't do is it doesn't actually give you the picture of how sick people are. There are a lot of sick people that I see in the emergency department who I may give some monoclonal antibodies to, but they're not quite hypoxic. Their oxygen levels are still reasonable. I'll send those home, and I'm hoping I don't see them again so that I end up having to admit them, and they may end up progressing to much more severe disease. So I think that the picture of the severity of the disease and how it affects you, as well as what we're learning now with long-term COVID and the sequelae from that, the brain fog especially that people may get afterwards so that they can't function. And one of the things that they found was people with severe COVID don't tend to get the long-term COVID. It's it's the milder forms, but the milder forms have an 80 times greater rate of unemployment, 80 times greater rate where they can't function anymore. And I think the statistic was like close to 35% of those that went back to work ended up quitting in 1 year because they couldn't function in the way that they normally could because of their long-term sequelae. So I think that there's a lot more in terms of just pure numbers. There's a lot more of those people walking around that are seeking help. And unfortunately, as Dr. Campbell was pointing out, there's so much that we don't know about this disease. And every day it's changing. And we may come up with a better vaccine, and I'm hoping we do. And it may be that this vaccine is going to not only target the spike protein, but maybe the nucleocapsid too. And that way it'll be a stronger and have a more robust and lasting effect. Things that we do know about some of the coronaviruses, we can get them multiple times. The HK61 and the others that are in that category. The more dangerous viruses like the MERS virus and the SARS-CoV-1, they actually have antibodies that last 12 years. So there are different coronaviruses. They don't always cause the same things in terms of immunogenicity. But I will say that I think that we're focusing on the right things. It's just we're coming up against a lot of misinformation. And that's what we have to take head on. And I think that that's where our focus needs to be.
Yeah. And I cannot help thanking Natalie for allowing us, for partnering us to have this event, so we'll get our key messaging across to people who need that. And Natalie, can I have your permission to ask Dr. Zappala for his take-home message before we start?
Absolutely, Dr. Stern. But there is also one more. Nancy in the chat has asked if she could ask a quick question. So however you'd like to.
Nancy.
Yeah, I just wanted to make a quick comment. I just wanted to, I'm in healthcare on the business side. I'm not a clinical person. I understand probably less than half of what you presented tonight, but I just wanted to say I really agree with Dr. Rice about the political environment. I think we're going to cap out soon in terms of the percentage of people that's going to be willing to wear a mask or willing to get vaccinated other than children. I just don't think we're going to move the needle that much anymore. It is what it is. This is our political environment. And that's why I'm all for things like employer mandates. We are so past the carrot. It's not the carrot anymore. I'm all for continuing with education. Education's always important, but I read an interesting article the other day about surging in Austria, and Austria has adopted a new regulation where if you are not vaccinated, other than limited circumstances like going to the grocery store, going to work, or going to the doctors, right now you can't leave your house. Now, that would never happen in the United States of America, of course, but I do think it speaks to really employer mandates and that sort of thing.
Thank you so much, Nancy, and I cannot agree more. We know that political mandates work. They worked last summer. We did not have, last winter season, we did not have flu. And once again, my last question is to Dr. Zappala. Steve, your take-home message.
Yeah, I think it's very simple to all the men, and especially to the women and the children, to encourage their men. Screening and early detection. Don't be afraid. Don't allay the fear and put away the anxiety. And finally, bring a friend when you come for your screening. We'll check him as well. Thank you very much.
Thank you so much. Natalie, the floor is yours.
I think on that note, I just would like to thank everyone. Dr. Campbell, thank you so much. It's been great to spend this time with you and hear from you, and Dr. Rice and Dr. Zappala and Dr. Stern. Thanks for just doing all the great work that you do, and for everyone that's attended. Thomas and Allie, thank you. It's been great working with you to produce this over the last couple months. Thank you for partnering with the NAACP, and have a great night. And please, if our branch can ever do anything to help any of you, just reach out and let us know. We're here.